Hi everyone, this is Neil Wright here, consultant audiologist and director of ClearWax. Thank you for joining me in part 2 of removing this earwax using the right angle curette. So it's what we call a manual extraction. And part 1 was of the patient's right ear. I uploaded that yesterday, so do take a look. I did provide a detailed case history in yesterday's video as to why I'm not performing microsection in this patient's ear, but I'll give you a brief recap. So this patient in their left ear has severe debilitating tinnitus, which would spike and exacerbate whenever they previously underwent microsuction. So for that reason, we're trying to remove this without the introduction of any noise. What makes it a bit tricky is that the entrance of the ear is quite narrow. I think I said in yesterday's video that their right ear was narrower, but actually upon review, the entrance here is quite slit. In addition, the wax in this ear is a bit softer and looser and wetter, which means as I'm extracting it, it's breaking away in smaller pieces. In addition, some of this wax is actually right up against the eardrum. At the moment, you can't actually see their eardrum. And using manual instruments very deep in the ear can be quite tricky, because the deeper we go into the ear canal, and if you've been following my videos for a while, you already know this, hopefully, but the inner 2/3 of the ear canal is made up of bone, and you've got the thinnest layer of skin. It's wafer thin, less than 0.1 millimeters in thickness. So if you make contact with the bony part of the ear canal, it's very sensitive. And I did again mention in yesterday's video, I do slightly abrase the back part of this patient's ear canal. I haven't edited it out, I want to show you. Now, spoiler alert, there is some wax going to be remaining, and again, I did mention it in yesterday's video. It's just because, as you can see, this wax is really wet, and there was some residual wax on the base of the ear canal, and as I was trying to remove it, it wasn't actually coming away. I was just spreading it, so I just left it. It wasn't going to cause the patient any problems. I showed him the video back, and in fact, before I went for that last bit, I did actually ask them, look, do you want me to try and remove that? And they said give it a go. But as soon as I went in, and I'll come back to that, I'll show you that point. So although I've removed a lot of wax already, we still can't see the patient's eardrum. At this stage, they're still struggling to hear. Now, what really facilitated me is the right angle curette. This patient last attended in 2023 prior to me. Well, I think the right angle curette was under production at the time, but I didn't physically have any with me, so I was using a straight curette, and it was very challenging when going deeper in the ear. With the angle curette, I've just got so much more maneuverability, control, and I can go far deeper. So I am slowly now approaching the eardrum. There's a little gap at the top, and I just want to flick this forward. I'm hoping some of the wax behind it comes away, and I think there's a smallest gap now I've created between the wax and the eardrum. But again, I want to tread very carefully. I want to avoid, number 1, touching the side canal walls, and also number 2, touching the eardrum. And I'm just at this stage flicking it away, but just by manipulating that bit of wax, the patient could hear significantly better already. They mentioned it. I said, well, have you removed all the wax? Because I can hear better. And I explained that the wax is still in there, the majority of the wax, but I've created a pathway. Again, I just want to go over and beyond. Now, when I first developed the right angle curette, there's some specialists, and they already using a different type of curette where the bend of the curette is about 30 or 45 degrees. And I purposely didn't design it that way, because the reason why I've designed the curette, or the way I at least use the curette, I imagine the worst case scenario, and that's when the wax is right up against the ear canal wall. So I want to be able to glide the wax in between, the curette in between the wax and the canal wall. Now, if the end there had a sharp bend, it'd be very difficult to get in and behind the wax. But instead, because I've got an angle on the handle itself, you can almost turn the curette into a 30 or 45 degree bend instrument. So you just go over the wax and you just rotate the instrument. So the reason why a lot of specialists wanted that significant bend is if there's an opening in the wax, they can get it behind and kind of it's easier to scoop out. They don't have to move their elbow or their wrist. But a simple rotation with the wrist or your elbow even, you can create that bend. Probably may not mean much for people who are not performing it, but hopefully it does. Hopefully I've explained it okay. So again, I just want to go. My heart was slightly in my mouth at this stage, I'm not going to lie, because you can see, even now, watching it back, you can see how close we went to the eardrum. Now, if I touch the eardrum, I'm not worried about perforating it because I was approaching it very delicately, but it's just when the patient, if they flinch, and I normally a patient, if they do flinch, they're going to go away from myself and the instrument, but you never know, they can come a bit closer. And it's more about comfort. So yeah, I mean, I'm pretty sure if I made contact with the eardrum, they may feel it slightly, but I was less worried about perforating it. Sorry, I've just got bits distracted. I'm getting a few messages and calls. So again, I'm just gliding at the base of the ear canal, and this is where it's beginning to spread like butter. And I think maybe I'm going to be tackling the back part of the eardrum now. We shall see. I think I'm lined up for it. I can tell by the angle of the camera. No, I was wrong. But I think that's the next bit. Again, I'm kind of going inside the inferior recess. And I was hoping, this wax was a bit firmer, it would have all come away. It would separate from the canal wall, but some of it's spreading. Now, in terms of the patient's hearing, they're hearing almost 100%. So in that respect, I felt like I did my job, but I just want to see if I can get a bit more out as safely as possible. And I think in a moment is when I do just slightly graze the canal wall, and I've inverted the curette, so the curvature is mimicking the curvature of the back part of the ear canal. And I think they did flinch slightly, which you may have not seen on screen because it was very controlled, but I think it's this next step. So I'm gliding, and I think just there actually, that's when they flinched. And you'll see a little red abrasion, nothing serious. I did show the patient back. And they kind of understood, they realised it's quite tricky using manual instruments because they have been elsewhere, and they do realise it's a bit tricky, especially with their type of wax. Don't know if you can see it, you will see it on screen, I will point it out to you. So I'm just clearing out the entrance. So I'm going to go back in, just it's not just there, about 11 o'clock. You can have a better view there. So just at the top of the ear canal on screen. Again, I've inverted the curette, so we've got the curvature mimicking the curvature of the base of the ear canal. So with the right angle curette, if you hold it one way, the curve is mimicking the top part of the ear canal and also the back part of the ear canal. And then if I want to go to the floor of the ear canal, there's a curette on either end of the instrument, so I spin it 180 degrees, and it means that the curve is now at the bottom. So it's very flexible. I think I managed to get a little bit more out, but not too much more. And I know I might get a lot of hate messages online. I'm already used to it, so it's fine, but it's all about patient comfort, believe it or not. I don't want to start cutting or grazing the ear. I've already caused a bit of trauma already, but I just want to mop up entrance a little bit more because the patient does wear a hearing aid, if I'm not mistaken, in this ear. And again, I'm just flicking it, little brush movements, because if I do make a bit more contact with the canal wall than I would like, I'm not continuously gliding it out. I'm coming back up again. So I'm reducing the exposure. They may be feeling a bit uncomfortable. There is a bit of a hair there. Now, it's not causing the patient any problems. And I think this is when I showed the patient, look, this is what's left. Do you want me to try and remove it? And I said, give it a go. And they didn't feel any discomfort, but as I was gliding, I was just spreading it, as you can see. So it was pointless in me continuing. Nice healthy eardrum. This is the same reel I played yesterday. So this is both their right and left ear, and the top half is of their left ear. So it's about a 50-50 split. There's the right angle curette on screen. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.